Hi, Dr. Young. Thank you so much for being on episode 2 of OCD. And today we're here to talk about OCD and mood disorders and how you approach the treatment, how you mix modalities, how we kind of address the whole person at Sheppard Pratt when someone's coming in with OCD. And in this case, it's mood disorders. So again, thank you for joining me for this discussion.
Absolutely. Really happy to do this. Thanks.
So if you could just give us a brief introduction about your role at Sheppard Pratt, just so people who aren't familiar with your work can.
Sure. Absolutely. I've done a lot of things around Sheppard Pratt over time. Right now, I'm the service chief of the Retreat, which is a residential program for adults dealing with mood disorders, OCD, anxiety disorders, often co-occurring together, substance use disorders. We provide comprehensive treatment for adults in a psychotherapeutic residential setting. So that's the majority of my job here right at the moment.
Great. All right. So I want to get started with just a very basic question. What does the word mood even mean? Because, we use it kind of colloquially as like, I'm in a bad mood, or I'm in a great mood. How's your mood today? We ask this of our patients, how's your mood? But then when you're talking about something like depression or bipolar disorder, mood doesn't necessarily just mean your attitude, for example. How do you define mood in this context?
Right. No, I think that's an important question. The way that I think about mood is it's a conscious state of mind or a predominant emotion, just as a basic definition of mood. Now, when we talk about mood disorders, that's a question. Everyone feels sad or depressed at times. Everyone feels out of sorts. Grief is a normal human reaction to loss. So when I'm talking about a mood disorder, I'm talking about a persistent state of depression or hypomania or mania. So when I'm talking about a persistent state of depression, this is symptoms that would include significant sleep disruption, loss of motivation or enjoyment of things, excessive guilt, lack of energy or concentration, appetite changes, sometimes slowing of cognition, speech, and movements, suicidal thinking. When a number of these symptoms are existing simultaneously for a prolonged period of time, and it's interfering with functioning, social functioning, occupational functioning, that's what we call a major depressive episode. So that's more than just feeling sad or depressed or normal grief in response to a loss. This is a persistent state of depression. When we talk about hypomania or mania, we're thinking of symptoms of feeling abnormally upbeat, wired, euphoric often, increased energy, sometimes to the point of physical agitation, decreased need for sleep, increased speech or talkativeness, racing thoughts, and distractibility. When you have a combination of a number of those symptoms together that persist over days and weeks and months, that's what we call a hypomanic, which is an attenuated form of a manic episode. And that's the hallmark of a bipolar disorder. When you have a cyclical mood disorder, depressions combined with hypomanic or manic symptoms lasting for a period of time, that defines a mood disorder. When the depressive symptoms coexist with the hypomanic or manic symptoms together, often we call that a mixed state mood disorder. So often we'll put that in the bipolar spectrum when we diagnose mood disorders, but that's essentially what I'm talking about. Not just a fleeting feeling of sadness or depression, but something that persists over days and weeks.
Well, it sounds like the thing that really makes the difference and sort of crosses over into the term disorder is that it's out of sync with the cultural context, with what normal expectations, right? So me being very excited about some having won an award or something like that and staying up all night thinking about how great it is, you wouldn't call that me being hypomanic. It would make sense that I'm kind of amped up and ramped up in the context of the experience I'm having. But if that experience was out of sync with anything else that would explain it, then you might be looking at whether it's a form of hypomania. And it sounds very much like OCD in that regard, where we all have unwanted intrusive thoughts. That's a normal part of the human condition. We all have rituals to kind of simplify our lives, or little things we do to make ourselves feel better. Again, part of the normal human condition. But when it's out of sync with reasonable cultural expectations of behavior and it's impairing functioning, we call it obsessive compulsive disorder.
Yeah, absolutely. I mean, we want people to feel that full range of human emotion, excitement, when things are exciting, increased motivation. We want people to be able to feel that high of life. We want people to be able to be in touch with there's the more negative emotions, sadness and grief and feeling down. When things are out of control in our life because of something outside of our control, a loss of a loved one, a loss of a job, financial strain, food insecurity, the pandemic, and all of the things that have happened with that. We're not supposed to feel flat or normal. We're supposed to be able to engage with our emotions the full spectrum of human emotions, and so those are not mood disorders to feel those extreme emotions at times. It's when it persists to a point that it's not our baseline, it's interfering with our life, it's keeping us from doing the things that we want to do, and it's getting in our way. Right. That's when it becomes a treatable mood disorder needing treatment.
Yeah, and I guess it could get in your way up to a certain extent and still not be considered a psychiatric disorder. Like you said, if you're grieving the loss of a loved one, there might be a period of time where you are depressed. You're having trouble sleeping and concentrating. You're not yourself. You're feeling out of touch. And then over time, that eases up as you kind of come to terms with what happened in your life. And if a certain period of time passed and you remained in that state, then it might transition into something more diagnostic.
Oh yeah, no, absolutely, and I think that's very important to remember. When we're experiencing grief, when we're experiencing those normal stresses of life that everyone goes through, that's a time to embrace that self-compassion. That suffering is part of the human experience. That others suffer in the way that we do. That those are times that we need to focus on self-care, being kind to ourselves, and acknowledging the humanity in our suffering. When things cross over into a range that is concerning to ourselves and others around us, when we can't get out of bed, when we're not eating and losing weight, when we're not sleeping, when we're not thinking clearly, when we're having thoughts of suicide, those types of symptoms that that are dramatically interfering with our life, that are crossing over from that expected range of grief into something that's debilitating. That's when it triggers that need for treatment. Now, normal grief, normal feelings of sadness can also be helped immensely by engaging social support, participating in a grief group. But when those symptoms cross over into us not being able to function in our day-to-day life over a period of time, that's when more professional help and more aggressive treatment is indicated.
You might not have the answer to this question. I'm curious that what causes one person to sort of get locked into a depression or a hypomanic state, and another person to come out of the state, but before it reaches that psychiatric, diagnostic criteria. Is it? I know in OCD we tend to talk about, you have a genetic predisposition, and then your life circumstances kind of either bring that up out of you and to manifest into obsessions and compulsions, or they don't. But there's this sort of underpinning that not everybody develops OCD, not everybody has a little OCD, as they say. There's some biological component to it that might not be fully understood, that's being brought out of you from your environment. Would you say that the same is true for things like depression and bipolar, that it's not like it could just happen to anybody, but there's maybe some biological underpinning that gets woken up somehow?
Absolutely. I think that's a very important point, and I think mood disorders are similar to OCD in that way. Now, often mood disorders will run in families, similar to OCD. The biopsychosocial model of depression, which is one that we embrace, The bio part of that, indicates that biologic susceptibility to depression. So when you have that family history, that biologic susceptibility to becoming depressed or to becoming manic, either a major depressive episode or an episode of bipolar disorder, that's when the stressors of life, the psychological stressors and the social stressors, can work along with that underlying vulnerability that's based in our genetics to bring about the full mood disorder. So that's commonly what we will see, is that when somebody has that predisposition for depression through family history or through a prior depressive episode, which indicates that underlying vulnerability for depression. And when you have that, and then that's combined with those psychological and social stressors, that's often when we see a mood disorder arise, which is why we've seen an increase, an uptick in mood disorder prevalence during the pandemic, with those high psychological and social stressors, interacting with a large percentage of the population that has that predisposition, biologically, for depression. We'll have an increase, a situation where there's an increase in mood disorders.
Yeah, I wonder if some people with maybe a lighter genetic load for OCD or depression or bipolar disorder, because of how long the pandemic has been going on and this constant promise of it's going to get better, and then this constant removal of that promise over a long period of time, you have the people who are sort of very predisposed to the stressors causing their disorders to rise to the top, and then you have people who are maybe less predisposed, but 6-7 months in, it's finally got to them.
Oh, absolutely, because stress, it's not only the intensity of the stressor, but it's the duration of the stressor. So the first 2 weeks of the pandemic, when there was the lockdown, where people were really supposed to kind of stay at home and not go into public spaces. That first 2 weeks, there was a big rallying, around that. People were working together, setting up Zooms for the first time. There was a novelty to it. But as the weeks and the months went on, and now coming up on a year of these pandemic restrictions, that the duration of that stress has continued to really weigh on people. And so the stress accumulates over time. I think that's definitely what we've been seeing at the retreat and in outpatient practice as well.
Yeah, something I've noticed in the OCD community at the beginning of the pandemic, and I've used this metaphor many times, that it felt like aliens had arrived and the UFO was just floating out there, and that sort of represented a clear and obvious concern that caused all of the OCD concerns to feel secondary to that for a brief period of time. Not for all of my clients, but for many of them, they felt a little relief from their OCD, because all day they're struggling with uncertainty about this or that. And then suddenly there's this big thing that's happening that's bigger than anything going on in their head. And it almost felt a little relief of like, well, okay, I don't need to worry about this obsession right now. I just need to focus on keeping my family safe, making sure, figuring out what's going on with my job. It was nice to have a real crisis, I guess. Right. And then over time, I've watched people kind of gradually get used to this way of living. And then all the OCD stuff starts to come back, except now it's also bringing its friend depression, which many people with OCD struggle with depression. It's certainly not uncommon, but many don't. And I'm seeing a lot of people with OCD that's getting gradually worse, and they're also dealing with depression, which is new for them. And they think I'm doing something wrong, and they almost become obsessive about being depressed. So it's a challenge.
Yeah, absolutely. And some people are experiencing those depressive symptoms for the first time with this prolonged social isolation, disruption of usual routines, and this prolonged stress is bringing out depressive symptoms and certainly exacerbating depressive symptoms in those who have had depression in the past, and in some cases bringing out depressive episodes for the first time, with this unprecedented prolonged stress.
Switching gears a little bit, you mentioned something earlier about mixed state bipolar, and this is just a subject that I find really, really fascinating, because I've encountered a few people where their primary complaint is that they're uncomfortable, and if you go to you go to a hammer, you look like a nail, right? So you go to many people specialize in anxiety and OCD. They say, well, you're anxious, and the underlying obsession, it seems like a health anxiety. What if I never feel better again? What if this thing means something's wrong with my brain? And they're doing a lot of Googling and kind of obvious kind of compulsive reassurance seeking behaviors. And then when you try to treat that like it's OCD by doing exposure and saying like, well, you need to accept uncertainty that maybe you'll never get better, or maybe you do have some terrible disease, they don't habituate to it because they're actually feeling physically unwell. It's not just an idea that they have.
Mhm.
And they're often given medications that are typical for treating OCD, and they get worse under those conditions sometimes.
Mhm.
And so a few times I've encountered this, and thankfully have learned a little bit about bipolar disorder. It's not like it's in the DSM explained very well, where they're depressed and they're agitated, and so they're experiencing both the low and the high bipolar at the same time. And you wouldn't think to call that anything other than anxiety, because there's no name for it besides maybe agitated depression, which just seems to be poorly understood. And then when they're treated for bipolar with mood stabilizers, they often do get better, or some other type of intervention for mood stabilizers. And what looked like OCD kind of goes away. I mean, they might be left with some of the residue of the behaviors they've been engaging in, the reassurance seeking, but the constant rumination and obsessive thinking seems to get a lot better. Can you explain what's going on in the brain of a person who is experiencing both the high and the low at the same time, that agitated depression?
Sure. Yeah. No. I think that's a very good point, this is where the experience in treating mood disorders can come in very key, because you're right. Mood disorders do not always fit into clear diagnostic categories that are listed in the DSM manual or anything. Often you'll have a presentation that doesn't really seem to fit exactly with a major depressive episode, or doesn't fit exactly with a manic episode, and presents largely with extreme anxiety. Some people can refer to a mixed state bipolar disorder. Some people refer to an agitated depression. These terms can really be used interchangeably in my mind in the clinical setting. An agitated depression or a mixed state of bipolar, it often takes on a physical nature, a physical agitation, a restlessness. It's an intolerable feeling, and these excruciating feelings of suffering, that accompany these symptoms, can lead to anxiety and fear that this will persist indefinitely. A state that is so intolerable. What if this never goes away? I mean, a terrifying feeling. And that's why these mixed states of bipolar and agitated depression actually presents a high suicide risk, because of that fear that this is never going to go away, and it necessitates aggressive intervention. So what we found, and often, and another aspect of it, often antidepressants can worsen this state. They can be activating. They can worsen that agitation, worsen that restlessness. They can make a mixed state of bipolar disorder worse than it was even before. So you go to your doctor or your primary clinician. You describe the depressive symptoms. You get started on an antidepressant, and then symptoms get worse. And that can increase a sense of hopelessness. Now, like you said, exactly right. Mood stabilizers like lithium, divalproex, known as Depakote, atypical antipsychotics, sometimes even neurostimulations such as ECT, can be very effective in this setting. And treating a mixed mood episode, a mixed state of bipolar disorder and agitated depression, often we see that intense physical anxiety, that physical agitation lifts away once that mood disorder gets treated.
It's fascinating, and it's scary to think that there are people out there who are kind of doing the best they can, going down all these diagnostic pathways and being repeatedly invalidated because they can't find the right treatment because they're not getting the right diagnosis.
Right, exactly. And often when antidepressants make things worse, that's a very key clue to us that we may need to change the treatment plan and treat this mood disorder with more mood stabilizing regimen rather than an antidepressant regimen, which is often tried as the first line when there's depressive symptoms.
So when you're working with somebody who you've accurately, you're confident in the diagnosis that they have OCD and they also have co-occurring depression. And the depression is, so intense and so heavy that in addition to their OCD issues, they're also really having trouble functioning, and not just because of their compulsions, but because of feelings of self-hatred, a desire to harm themselves, things like that. Do you try to hit the ground running on both fronts, both thinking of the medication and the psychotherapeutic treatment, or do you think about, well, what's the greatest risk to the person's life? Let's make sure that's addressed first, and then once that's addressed, let's look at the other stuff.
Exactly. So it's a very good question, and it really depends on each individual case. So the two approaches are, one is what we call the onion approach. We treat the things that, on the outside that need to be treated first, and then over time we can kind of peel the layers of the onion and treat those deeper levels in those co-occurring disorders, after we address the most acute issue, on the outside. So one example of that is treating bipolar disorder that's co-occurring with ADHD. The treatment of bipolar disorder often needs to take precedence. We need to stop the stimulants if they're treating the ADHD, for example, treat the mood disorder and make sure that that's stable, and then we can go to that deeper level of the onion and then treat the ADHD that's co-occurring. Now that's one approach. That's the onion approach. Now the approach we typically take at the retreat, and is usually the best intervention with co-occurring disorders, is to treat both things simultaneously. So for example, if someone's presenting with co-occurring or triple occurring mood disorder, OCD, substance use disorder, perhaps other things, the best, most comprehensive approach is to treat each of those things comprehensively simultaneously. Now, there are certain cases where the severity of the mood disorder, whether if someone is in a florid manic episode or a very severe depression where they can't get out of bed, that could interfere with the ability to do any kind of cognitive behavioral therapy or participate, in a psychotherapeutic process. And in those cases, aggressive treatment of the mood disorder takes precedence. The symptoms of the mood disorder supersede the symptoms of the OCD, or even mask them, or even are present, and the OCD symptoms are less present at those times. So in certain cases, we do need to address the mood disorder as the higher priority. However, most of the time, what is possible is to address the two things simultaneously. So the symptoms in one of the disorders don't interfere with treatment of the other. So by addressing the symptoms of both of those things simultaneously, you get the optimal response and the most efficient response. So typically, I embrace the co-occurring approach of treating both things simultaneously. Occasionally, you need the onion approach, where you treat that outer level, those more severe, more prominent symptoms first, and then to get to the others. But it's good to have a comprehensive treatment plan that addresses each of those disorders comprehensively.
Yeah, I think in something less than the most severe cases where you need to take that onion approach, but still quite severe, the issue is that the OCD and the depression are informing each other and exacerbating each other, right? So if I'm going to do the brave work of exposure therapy and resist this compulsion and sit with that anxiety that comes with not knowing if my fear is going to come true, I have to have some sense that I'm capable of doing that, and some sense of confidence and competence. And if I have depression pulling down on me saying, you can't do things, you're bad at everything, nothing works for you, then I'm not going to be able to do, or I'm not going to be willing to do the OCD work, or I'm not going to learn from the OCD work that I can get better. I'll kind of talk myself out of it. And then because of my compulsions and the things I'm avoiding, I'm not doing the things I really value in life, which is also feeding my depression. I'm feeling disconnected from my family and from society. And of course, COVID makes everything worse. The disconnections are even greater there. But even without that, this is what I've seen a lot of, where they're tag teaming. The depression is trying to keep you from doing the OCD work, and the failure to do the OCD work is inviting the depression to take center stage.
Absolutely, and we see that with many combinations of co-occurring disorders, whether it's mood disorders and OCD, or mood disorders and substance use disorders, right, or mood disorders and physical conditions like severe chronic pain. in all three of those circumstances, addressing both of those things simultaneously is more often than not the way that you need to approach it to be most effective.
Do you think of mood disorders as chronic, and the way we talk about OCD as chronic, and that it waxes and wanes throughout your life, and you have to have skills for mastery over it? It's not like you take a pill and you're cured and you don't have to worry about it ever again.
Yeah, no, it's a good point to bring up. Like I mentioned before, mood disorders are complex. They have biologic, psychological, and social aspects contributing to them. And one episode of major depression can indicate that underlying susceptibility to that depression recurring or future episodes of depression. Therefore, our goal in treating a mood disorder is to put an episode of the mood disorder, whether that's a depressive episode, a hypomanic episode, a manic episode, or a mixed state, to put that episode in remission and then maintain treatment to keep it there. So I may figure out the combination of medications that keeps the mood disorder at bay. And I may need to continue maintenance on those medications over time. Sometimes lifestyle interventions and psychotherapy are key interventions to keep the mood disorder in remission. For example, in bipolar disorder, once that manic episode is resolved, maintaining a lifestyle with attention on healthy diet, good sleep hygiene, regular exercise, minimizing stress, maintaining those solid lifestyle interventions greatly reduce the recurrence of that bipolar disorder. So you can see that the comprehensive approach is essential. But we do know that one episode of a mood disorder does predispose to future episodes and puts somebody at increased risk of future episodes. So we do know that those lifestyle interventions and maintenance treatment is essentially important. But that's the goal, is to put the episode into remission and to keep it there.
I would imagine also family therapy probably plays a role in both disorders, but with OCD, training families to understand what's going on with their loved one, how to offer support without contributing to compulsive reassurance and avoidance, and facilitating the OCD coming back. And I would think also with depression, like you said, there's certain stressors that can bring it out of a susceptible person. Those stressors might be conflict at home or something like that would also have to be addressed, because all the medication in the world and all the good ideas in your head, and then you go home and there's fighting and other things that are kind of pulling your depression out from that remission. That has to be addressed as well. Like the whole system, not just the person, needs to be treated.
Sure, the psychological and social stressors that I'm talking about are often related to feeling that lack of validation or lack of understanding from others, even in the family unit or the people close by. So by family members being educated, by loved ones being educated, being a validating source of hope and compassion and support, by understanding and helping a person engage in the lifestyle that helps keep the mood disorder at bay. That positive social support can be key aspect to healing and keeping things in remission. If those people close to us are providing an exacerbating stressor, even if it unintentional, that makes it that much harder to keep the mood disorder at bay. And similar to OCD, the family unit needs to intervene in the appropriate and the most effective way to be helpful. It's just similar with mood disorders.
And with the psychotherapy for, I guess, primarily for depression, you think about behavioral activation, and my understanding of behavioral activation is it's essentially learning to think paradoxically and do the opposite of what your body and your brain is telling you to do, right? Your body and your brain is telling you to isolate, so you engage in social behavior. It's telling you to stay in the dark, so you open up the blinds. It's telling you don't deserve to eat, so you make yourself a nice meal. And you're kind of kickstarting the brain to say, we don't need to follow these rules. We're going to do therapy instead. And exposure therapy is very much like that as well. It's saying, this is scary, you can't handle it, so we're going to do the hard things. We're going to do the scary things to learn that we're capable of doing it. Are there any fundamental differences between behavioral activation for depression and ERP for OCD that you can think of that really make them different treatments, or are they really the same kind of treatment but for slightly different problems?
Yeah, I think the similarities are much more easily identified than the differences. The cognitive behavioral therapy, behavioral activation is really at the core of that. The aim is to increase engagement in adaptive activities, decrease engagement in activities that maintain the depression or increase the risk of depression. So very similar to ERP in that way. Increase the effective behaviors and decrease the behaviors that interfere with functioning. And another similarity is that it's a highly, behavioral activation is a highly personalized intervention. And then you target the behaviors that feed into that depression, similar to the way that ERP targets the behaviors that feed into the OCD. I think that they have there's strong similarities of opposite action. I think it's at the core of CBT, and it's at the core of psychological treatment of depression, similar to the way that ERP is for OCD.
And in terms of psychiatric interventions, it seems like the first line of treatment for OCD and depression is something like an SSRI, and you typically see lower doses for depression and higher doses for OCD. And no one's ever been able to answer the question why. Right? Like, why does it just seems to work when you get up to that higher dose? It seems to take on those anti-obsessional properties. And I don't know if you have any sense of why that would be, or if it's just something that was sort of discovered in the course of experimenting with these medications.
Yeah. The mechanisms of action of centrally active medications, of medications that are prescribed to address psychiatric disorders, are generally very, very poorly understood in general. We know that the selective serotonin reuptake inhibitors, the SSRIs, are very helpful in addressing a range of psychiatric disorders. They're very helpful in addressing anxiety disorders, for example, very helpful in treating depressive disorders, very helpful in treating OCD. What we've noticed over time is that, often with depression, the optimal dose of the antidepressant, when you're balancing effectiveness versus side effects, is often at that lower range of the dosing. Fluoxetine, known as Prozac, a very commonly prescribed first-line SSRI medication, it's been on the market for, I would say, more than 30 years now. It's FDA approved, indicated for depression, treatment-resistant depression when you combine it with an atypical antipsychotic like olanzapine, OCD. Often these SSRI medications like the Prozac or sertraline, known as Zoloft, also indicated for major depression and OCD. Often we see that the OCD symptoms are better relieved at those higher doses. Now, the SSRIs work through the serotonin system in the brain. Serotonin is one of the key monoamine neurotransmitters that has a lot of functions in the body. What we see at higher doses often is effective for OCD symptoms. There are other medications that are specifically helpful with OCD. One of those is a tricyclic antidepressant called clomipramine, sometimes known as anafranil as a brand name, but that can be particularly helpful. And what we also find is that sometimes a combination of medications, not only antidepressants, but a class of medications called atypical antipsychotics, which are commonly used as adjunctive treatment in depression, commonly used in the setting of bipolar disorder. They can also help the overall picture when there's co-occurring OCD symptoms. So
these are usually at very small doses, right? When you're adding
atypical. Often when you're prescribing these atypical antipsychotics for mood disorders or OCD, you're talking about on the lower dosing range, whereas they may be at the higher dosing range when you're treating a psychotic disorder like schizophrenia, for example.
Yeah, I think there's a lot of stigma around medication, and I almost fantasize sometimes about the idea that the drugs could have different names based on their dosages. right? So having an atypical antipsychotic sounds very scary, but when you're taking a dose that's so tiny and it's actually there to help you with your mood disorder, I think a lot of people would wish for it to just be called something else, because they're afraid to take that step into this whole other world that they don't relate to, or a disorder that they don't have. Especially I see with OCD, there's really common to have mental health anxiety, right? Even I'm sure there are probably people watching this right now who are thinking, oh no, am I bipolar? Am I depressed? That they don't want something more than OCD. Sometimes they have something with OCD and it's totally treatable. Sometimes they only have OCD and they don't have a comorbid condition, but the OCD is so intense that it requires a multi-medication approach that can really work. But I think a lot of people are afraid of doing that because it just sounds so scary.
Yeah, yeah, and that I think that's true, and I think it's one important framework to keep in mind is that we want to we want to have a narrative where we're not stigmatizing ourselves because we're having symptoms. A lot of the time the diagnoses can sound scary: major depression or bipolar disorder or obsessive compulsive disorder. At the same time, where what we're basically doing is acknowledging symptoms that are interfering with our life and taking a proactive intervention to relieve those symptoms. We're taking a bold step forward, we're demonstrating courage, we're trying to proactively step toward wellness. I mean, by just acknowledging things as they are, symptoms we're experiencing, and trying to make them better. So I think if we maintain a positive frame, everybody deals with things, certain medical issues in their life, whether they're mental health conditions, other physical health conditions like diabetes or hypertension. Over the course of a lifetime, everybody experiences medical symptomatology. And I think if we can minimize the self-stigma we can feel about having these symptoms and take a proactive approach to addressing them and striving toward wellness, we are really ahead of the game. And I think it's a good lesson for life, whether we're experiencing psychiatric symptoms or not. We're trying to optimize our life and live as healthy a way as we can.
Yeah, I think people get confused. They sometimes think that they chose their symptoms somehow and that they're personally responsible for having them, and that it represents some failure on their part to figure out how to live. So you've treated some of the most severe cases probably anybody has encountered just working in the residential environment at Sheppard Pratt. And I guess to end us on a good note, is there always hope? Have you encountered cases where the patient is without hope? They've been on every medication under the sun, they've tried all the treatments, and you were able to find the lever to pull that actually opened up the clouds for this person, and you were able to see their life come back, or see them re-engage with life. And that's my favorite thing about working with OCD, is seeing people re-engage with the things that they were passionate about that they had lost to the OCD. Have you seen that with your work with mood disorders as well?
Oh, absolutely. We see that frequently, every week and every month. We see that all the time. A lot of the time people come into residential treatment after having tried a number of other things in the outpatient setting. What we often find is a couple of things. One, the diagnosis has not been accurate and comprehensive. And two, there has not been a comprehensive treatment plan to address each of those co-occurring disorders. So what we frequently see at the retreat, and what's frequently seen in any setting where a true comprehensive treatment plan is applied, that once you get accurate and comprehensive diagnosis about all the co-occurring disorders, and once you put into play an effective plan for each one, and then you combine that with the treatment time that it takes, we consistently see great improvements, often putting symptoms into remission when that hasn't been the case previously. So we maintain a very hopeful approach. We work with people that are hopeless in terms of how they're feeling when they come in, until they start feeling that glimmer of hope, and then that builds gradually over time. So that's why I do this work. It's very rewarding to me to help people go through that spectrum of feeling hopeless with their symptoms, to having that glimmer of hope, to ultimately overcoming their symptoms and getting on with their life. And it's a beautiful journey And we see it with OCD, with mood disorders, and even in situations where the treatment course has been frustrating up until this point.
Well, that's fantastic. Well, Dr. Young, thank you so much for your time, and I hope everyone who watched this learned a lot and remembers the central thesis here, that there's always hope. Thank you very much.
You're welcome. Thank you for doing this.